Welcome, everyone. I'm Dr. Cindy Grines, SCAI. I'm the Chief Scientific Officer at Northside Hospital Cardiovascular Institute. Today, we're going to be discussing a very, very interesting paper by Dr. Anthony Mathur, and it's a meta-analysis looking at proangiogenic growth factors for refractory angina. With us today, we also have Dr. Tim Henry from Christ Hospital in Cincinnati and Dr. Dan Burkhoff from CRF and Columbia University. Welcome, everyone. Anthony, I wondered if you could just give us an overview of what the study showed.
Yeah, absolutely. Hopefully you can see my slides, and thank you for the introduction and the opportunity to discuss this. So this is all about the proangiogenic growth factors as a treatment for refractory angina. We believe it's the first meta-analysis that has specifically looked at these factors, and the factors that we're talking about are VEGF and FGF. We used standard meta-analysis methodology to basically screen through more than 300 citations, but based on our criteria, that got us down to 16 randomized controlled trials, because it was important for this analysis that we had a control comparator group in some form or other to make the comparisons and run the analysis. The headline news was that even though there are only 16 studies included in here and a relatively small number of patients in the grand scheme of things, those 16 studies did actually report a beneficial effect on MACE, which again is the first time that a therapy, particularly in refractory angina, has come across in this particular way, with the exception, ironically, of stem cells. So it's quite interesting that conventional therapies that are out there don't have the same signal. So we were quite surprised and interested to understand this finding. We'll see also that looking at the positive results of this paper, when we looked at CCS class, and here we're looking at mean value at endpoint, again, there was a significant reduction in CCS class, again, supporting some of the potential beneficial signals that we're seeing of angiogenic protein therapy in these patients, such that it was really the patients that got treated in the experimental arm that saw that reduction, with patients in the control group maintaining the same level of CCS class, if not getting worse. We didn't see a statistically significant difference in mortality, but again, you can see from these tables that essentially there is a trend towards mortality, and I'm sure we'll get to discuss that later, but bear in mind, it's not a vast number of patients. Bear in mind that actually your survival with refractory angina these days is pretty good. So one could argue that there is a fundamental issue anyway when we're doing clinical trials and using mortality as an endpoint, because we will need to basically recruit patients that are likely to have a large number of events. You'll see also that total exercise time here again moved in the right direction, but again did not reach statistical significance, again perhaps talking to the fact that there weren't a vast number of patients in the study, but also there's considerable heterogeneity in the way that these tests were done, the type of testing that was used. Again, talking to some of the issues to do with meta-analysis and comparing the various studies that are out there. So what are the implications for clinical practice? So I think this is the first time that we have demonstrated an effect of proangiogenic proteins on improving the clinical symptoms of refractory angina, and interestingly leading to a MACE effect. Obviously, this is very provisional data. Mechanistic questions arise as to how this has all occurred, beyond the obvious that we're growing new blood vessels and revasculating. But essentially, there needs to be quite a lot more work to truly understand what's happening in our patients. I think it's fair to say that this is promising, but early phase. And so essentially, given the burden of refractory angina and the problems that I think we all face as interventional cardiologists, so that when we see these patients in our clinic, sure, we've got complex revasc, we've got coronary sinus reducer, we've got various other things to offer, but equally, we also know a large number of these patients do come back. So having something that is in the form of a biological therapy, and as I said, this sort of goes hand in hand with some of the data we're seeing from cell-based therapy, I think starts to build up a series, an armamentarium of treatments we could potentially offer this increasing group of patients, which, as you can see from this chart, are putting, quite a burden on the healthcare system. And I think we as clinicians are always sort of struck with the difficulties of managing these patients and the empathy that we have for the problems that they have, and the fact that we feel a bit helpless. There's often not much that we can do. So I think with respect to treatments, it's great that there's more the merrier, but again, hazard warning, early stage meta-analysis of 16 studies. And that really what we need to do is start working together to define or create larger studies. To be very clear, as I mentioned, there's a lot of heterogeneity in the way these studies were performed. So again, not just in this field, but many others, we do need to be very careful as to how we define our endpoints and how we measure things. And obviously, before this gets anywhere near clinical practice, there's still quite a long road to travel along. So I think that's the nuts and bolts on it. Promising stuff, but early days.
Thank you so much, Professor Mathur, for that very interesting meta-analysis. I have a question. I mean, with regard to angina class, it was very striking, the improvement, but were these studies all placebo-controlled, and were the patients blinded to the therapy they received?
The reason we got down to 16 randomized controlled trials is that we were trying to be very, very careful about making sure that there was a control or comparator arm. So for the most part, the answer is yes. There are a few studies in there, and one might argue that the comparator arm wasn't exactly a placebo controlled, where there was some sort of sham, but as far as having an invasive procedure, that didn't always occur. But again, that is one of the drawbacks we have in meta-analysis in the way that we do that. But essentially, these were all looked at and analyzed with respect to meeting the criteria for randomized placebo-controlled trials.
Excellent. Yeah, that's important. So, because so many of the meta-analyses include observational trials. Dan, what is your read on this meta-analysis?
Yeah, so thanks, Cindy, and thanks for for inviting me to participate here. This is great. We were fortunate enough to be asked to write the accompanying editorial, so we did have a chance to dive pretty deeply into this paper. And one question, Anthony, I really was burning in my mind as I was reading this is, what motivated you to write this paper? Because if you look at the studies are between 10, for the most part, 10 and 20 years old. So why now, after 10 years, did you think it was important to bring these older studies together? There's, of course, a host of other questions to ask, but this was one that I really was a burning question that I had.
Yeah, and that's an incredibly interesting, not even philosophical, but personal question, I guess, that's come across. So as Tim will also recognize, I've invested a lot of time, as Tim and others, in the world of cell therapy or biologics to treat heart disease, whether it's heart failure or moving into refractory angina. And as you know, that particular field has struggled for a long time with respect to stem cells and a lot of the critiques and difficulties in firstly demonstrating an effect. And of course, there's been a tremendous amount of controversy that has accompanied the field. But one of the burning questions about cell-based therapies is, can we cut out the middleman? Can we actually get rid of the cells and just actually take what it is they're secreting to actually get the effects that we hope would happen? And so for that reason, having spent the last nearly 2 decades looking at cell-based therapies and running phase 2 and phase 3 clinical trials, it was of interest to us to actually sort of reflect on whether we had taken the wrong approach, and that really what we should be doing is being very specific and looking at proteins that have got a mechanistic explanation in the form of angiogenesis that sort of tick the boxes, because again, we do struggle in a clinical basis to explain how cell-based therapies might work, even if and when we do get a signal. And part of that is some of the limitations in how we can measure clinical mechanism in human beings. There's lots of animal work supporting cell-based therapy about angiogenic proteins as well, but of course translating that into human beings is difficult. So the answer to your question is that my background comes from seeing what's been going on with cell-based therapies. We've seen a strong signal in cell-based therapies for the treatment of refractory angina. We do all realize that it's logistically challenging and can be quite expensive to deal with cell-based therapies. And so really what motivated us here is to address the fact that maybe it's a single protein that can make a difference, which potentially makes it more marketable, more affordable, and hopefully more efficacious. So that's why we did this.
So getting back a little bit to the basic science, that underlies all these kinds of therapies, and right to your point, do you think it is biologically plausible that a single molecule, will be able to do the job? And one thing that we have been thinking about since the early 2000s, late 90s, when all this stuff kind of started, was most of these factors primarily generate small capillary networks and angiogenesis. And it's okay if you make a network, maybe it's one thing to generate a network of capillaries that are in the regions of the injections, but how do those capillary networks get hooked up to the epicardial vessels? And is there a step in between arteriogenesis and vasculogenesis that generate the real robust connections to the epicardial vessels? I mean, this is where I've stumbled since the early 2000s. Is the let's say that there could be a little bit more robust basic science to substantiate that these approaches could actually lead to meaningful improvements in perfusion. And also, in your paper, you also pointed out that in those studies that looked at perfusion, there was really very mixed results in terms of perfusion. So has there been any advances in the basic science that say now it's time to reflect or to renew our interest in single molecule approaches to chronic angina?
So I'm no expert in the basic science, but the overall view of the field, and including the cell-based therapy. So I totally share your, not so much skepticism, but the question about how we get this to all join up and make sense. I think really what this paper is telling you is that we have a signal, and that we also do have a provisional mechanism. And I totally accept your point that the mechanism of angiogenesis starts to fall down a little bit when you start to think it through and go from capillary networks to how does that join up to epicardial vessels. I think in the animal work that's been done for the last nearly 2 decades that precedes this, there is evidence that perfusion does improve in response to an increased capillary density, and that potentially arteriogenesis is also something that happens. But as you well know, having tools that allow us to demonstrate that in patients is very difficult. And to your point about perfusion, one of the problems that we've got is getting reproducibility and perfusion analysis and finding it as a sensitive enough tool to actually be used in these trials. So again, when we looked at perfusion here, and as you rightly say, didn't see an overwhelmingly mechanistic explanation from the data that we had, we also realized that people had used different protocols, they'd used different imaging modalities to do this. And again, that sort of weakens our ability to actually make sense of this, and goes back to what I was saying about the need that we've spoken about again for decades about standardizing our approach to these areas. So I would say to you, I totally agree. I think there are big mechanistic questions, particularly since, as I mentioned in the discussion, that the reduction in MACE is driven mainly by myocardial infarction, and how a capillary network prevents a plaque rupturing, which presumably is the mechanism that's causing these infarcts, is something that we have to work on and to determine. But what we put this against is the fact that we have a challenging field in which, despite the fact we have got some very invasive and expensive treatments, we're actually getting a better signal from a biologic, albeit with some mechanistic questions where we're rightly asking the mechanistic questions. But things like doing complex interventional work to revasc these patients and whatever is expensive, it's potentially dangerous. And the data really isn't that great. I mean, we had this for years trying to find a signal for revasc, and we are struggling big time. So I do think the interesting paradox is here we go, 16 randomized controlled trials with an angiogenic protein, and we've got a signal. Years of putting stents in, designing microcatheters, lasers, and to some degree coronary sinus reducers, and we're not getting the same signal. So yeah, I don't quite know what's going on here, but we have a provisional mechanism, and we have something that if we can follow it through, joins the list of all the other things I just mentioned that we might be able to offer our patients to make them feel better.
Yeah, I'd like to comment that since I enrolled many of those patients, both Tim and I were, the PIs of 4 of these trials, that at least in our studies, we included patients that had chronic total occlusion lesions that might benefit from increased capillary density, improvement collateral flow. And so that might be a mechanism for, this reduction in angina as well as the reduction in MI if the supply-demand mismatch is more normalized. Tim, I'd like to hear your feedback and also comment on variability in exercise time and how you're going to manage this in your coronary sinus reducer trial.
Yeah, so there's a lot here, and I love Dan's comment because it's very insightful and like, why now and is it timely? And so I'll make a couple things where I think it's very timely. Number one, the patient population. So it really focused. This is a group of people with refractory angina, and we still call them so-called no option patients. So these are patients who have a significant limitation in their activity because they have chest pain with almost everything they do, and they're not candidates for further revascularization, and they've optimized their medical therapy. Well, here we are 20 years later, we still don't have good treatment options for this patient population. And it's growing because people are living longer. And Anthony mentioned this earlier, but the mortality in this patient population is actually quite low. The problem is quality of life. So number one, I think we recognize that there's a lot of these patients out there. Number two, I think that we went from protein therapy to gene therapy to cell therapy. Well, one of the issues that really came up, and I'll emphasize it, is with cell therapy, you see the same signal with improvements in symptoms, but cell therapy the business model is not as good. It's much more expensive and it's much more difficult to do. And the third really key point is I think we've come a long ways with gene therapy now. So where you have a gene therapy, the business model is much better. It's much cheaper to do it. There are challenges. We can talk about delivery in a minute, but what you can do now is the vectors are much better than they were 10 years ago or 20 years ago. So now you actually can we just doing a trial in heart failure where we're doing a cardiac specific adenovirus so that you can actually design a vector that's specific for the heart. Number two, the gene products, the way we can do it with vectors now is that you can have more than one gene product. So there's a trial that just finished that is encoding for multiple isoforms of VEGF, for example. So this is very timely because there's a number of new trials that are just starting where we have better vectors and better gene products so that allow us actually to do this in a more efficient manner.
Thank you very much. Any remaining comments from the group?
I think if I might add to Tim's point, he touched on delivery. And again, if you look in the paper, I didn't present it in the slide deck. We have a bit of a problem with the withdrawal of one of the main intramyocardial injection systems that we've been using percutaneously, withdrawal from the market. And so another big question that sort of hit this and the field of cell therapy is, oh my God, what do we do now? Because the perception was that the targeted delivery directly into the myocardium was the most effective method. And again, what I found interesting in the results of the meta-analysis is that actually the majority of the signal for a positive effect came from intracoronary delivery. And to Tim's point about the vectors, albeit these are old papers, it was adenovirus that seemed to be the best way of delivering the treatment. So I think that notwithstanding, there are still some techniques that we can use for intramyocardial, but again, it brings hope to the field that intracoronary might well be just as good, if not better. The meta-analysis tends to suggest that it does work, and that adenovirus is actually your vector of choice in delivery.
And Cindy, can I make one more point too about this whole field? I think another thing that's really changed is we really are becoming aware of the importance of the microvasculature. So it's not just people with advanced coronary disease, but there's a lot of patients out there that have microvascular dysfunction. And that's, so this so-called INOCA or ANOCA patient. But also that's true in other things like HFpEF, for example, where the microvascular is abnormal. And I think that it seems more clear. We have better data now that shows that the way this works is by improving the microvasculature. So this might not just be a treatment for people with advanced coronary disease, the no option patient, but it might also be a good and appropriate treatment for patients with microvascular dysfunction as well.
Excellent. Well, I really look forward to these future trials and techniques, and it sounds like it has an exciting future. I want to thank everyone for participation today, and thank you so much for this outstanding paper.